We are the Center for Advancing Health Outcomes. Research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Good afternoon, everybody. My name is Frank Schiermeyer. I'm one of the emergency physicians at St. Paul's Hospital. Today gives me great pleasure to introduce Dr. Amanda Slaunwhite and her team. I've known Dr. Slaunwhite for about 7 years now when we started working on the patients or people with opioid overdose. This is an ambitious program here. It's called the Prevail Project. The title is Implementing a Peer-Led Program to Reduce Overdose Among People Leaving Incarceration. Now, as an emergency physician at St. Paul's, a disproportionate number of people I see who've just experienced an opioid poisoning have come out of enforced abstinence, and often it is incarceration, so it is a huge deal. This presentation will outline the findings of a peer-led project that aimed to reduce mortality among people leaving provincial correctional centers who are at extreme risk of drug poisoning when they return to the community. There are 5 people presenting today, so a very brief bio on all of them. Dr. Amanda Slaunwhite is a population health researcher with expertise in prison health, substance use, and mental health, who just published in BMJ last spring, if you want to check that out. She has more than a decade of health experience working with administrative health data in North America and has co-led research projects with people with lived experience of substance use, incarceration, and overdose/poisoning. Kate Roth is a research manager with the Canadian Collaboration for Prison Health and Education. For the last 5 years, she's dedicated to community-based participatory research that promotes the health and well-being of people with a history of incarceration. Dr. Beth Snow's work focuses on bridging the gap between research and evaluation evidence and health services delivery, and has conducted evaluations in a range of settings in community, public health, and acute care and long-term care. Jenyo Banjo is an evaluation specialist with the Center for Advancing Health Outcomes and has spent years of experience with mixed method research and is an evaluator in the BC Healthcare. And finally, Korchinski is the executive director of Unlocking the Gate Services Society. Her lived history and experiences of substance use and incarcerations have shaped the program into what it is today. Mo is a strong advocate for people involved in the criminal justice system, has worked for many years in the field of community-based participatory research alongside the Collaborating Center for Prison Health and Education at UBC. Thank you.
Thank you so much for coming today, everybody. I'd like to first acknowledge, of course, with extreme gratitude and appreciation that we reside here on the unceded ancestral and traditional homelands of the Musqueam, Squamish, and Tsleil-Waututh nations and what is colonially known as Vancouver. And we're going to start with a brief background on the health of incarcerated people in BC and kind of how we got to this project a few years ago. So I think most people are aware that people who are incarcerated experience vast health inequities compared to people who do not experience imprisonment. And in recent years, over the past decade, this has really come into focus, and especially here in BC over the past few years, where there's been increasing attention on the mental health and substance use of people who've been incarcerated. This is from a study that came out a few years ago, looking at trends in mental health and substance use disorder. And what you can really see is that our clients, the people we see in provincial correctional centers, they are disproportionately now experiencing concurrent disorders. So that is both mental health and substance use disorder. We know that there's increasing acuity of these disorders experienced by people who are incarcerated that are really elevating and expanding the health inequities that people experience. Next slide. We know that the health of incarcerated people is very linked to the ongoing overdose crisis here in BC, and that to address the overdose crisis, we really need to address some of these health inequities that incarcerated people experience. So this is data from the BC Provincial Overdose Cohort. And we looked at among people who had had an overdose, what proportion of people had been previously incarcerated during that period. And just over a quarter of people who had an overdose from 2015 through 2020 had been previously incarcerated in a provincial correctional center. And so responding to the overdose crisis and improving the health of incarcerated people are really, really linked. So we must address one to address the other. Next slide. We also know from our research using administrative health data that there are particular periods of time where people are more or less likely to have an overdose. And this was research we had published a few years ago, looking at when people are most at risk of having an overdose event. And really what you can see here is that on the day of release and in the first 2 weeks post-release, people are at extreme risk of having an overdose death and an overdose event. Overdose events are much more common in this time period than any other time period when people are making that transition into community. And that really led us, this research really led us to developing and working with our partners at Unlocking the Gates to develop the Prevail project to address overdose risk post-release during this 2-week period. And I will now turn it over to my colleagues. Thanks.
Okay, so we were looking at people living correctional centers in BC who have had history of illicit substance use in the 6 months prior to the time when they were incarcerated, at the time we were contacting them. Recruitment was done by Unlocking the Gate staff members who are people who have lived experience of incarceration and substance use. And we had 3 time points for collecting data. The baseline data collection was done on the day of release, and our recruitment was done on a rolling basis. So as people come out of correctional facilities, they get contacted to find out if they're interested in participating. And if they consent, a peer person contacts them on the day of their release and provides some peer support, including, providing transportation services from the correctional facilities to wherever they want to go, and also providing them with some materials as part of our project, which include a cell phone that has a preloaded data plan to help them reconnect and reintegrate into society, and also to reconnect to some health and social services. And our data collection was done through surveys and interviews. And so we had that data collection point at the baseline on the day of release, and then 1 month after their release, we contact them again for the first follow-up. And then 2 months after their release, we contact them again for the second follow-up. So at each of those 3 time points, we do surveys and interviews with them. So like I said, participants are provided with one-on-one peer support with people with lived experience who are members of Unlocking the Gates Found Society. They also get cell phones that are preloaded with overdose prevention apps. And like I said, 3 months data plan to help them, reconnect with life and their loved ones. And they also get a care bundle that includes a naloxone kit, some toiletries, and some other personal items to help them get back into the swing of things. And for Indigenous people or other people who are interested, they get a medicine bundle from the Chimamok Society that was packaged by them. Sorry, so just one thing I wanted to emphasize again is that because this is a peer-led study, all contact with participants were done by people with lived experience. So we as researchers didn't actually have direct contact with participants. The Unlocking the Gate staff members actually did all of the surveys and interviews with them, but they were trained by us to help them develop the knowledge and the skills to do the qualitative interviewing. So I'll pass it over to Mo now to talk about Unlocking the Gates.
Okay. So Unlocking the Gates is a peer-led organization. So everybody who works with Unlocking the Gates have all been incarcerated, just because no one knows what it's like walking out of those gates except for somebody who's been there. So we work with all 10 correctional centers across the province. So it's 2 years less a day sentences. We do release planning. Our phone's free in all the correctional centers, so everybody can always get a hold of us. Our phone's on from 6 in the morning till 10 at night, 7 days a week. What's super important, because if you're locked down, you don't get out till 8 o'clock at night. No one answers. We always hear no one ever answers our calls except for us. So we meet people the day they get released. You know, it's definitely changed. I've been doing this 15 years. So important for us that we pick people up from the gate and they get to where they're going alive. So peer support in the community. We also do a probation program. We've expanded since 2020, where we support people now in the community. So if you get a court-ordered condition that you have to report every week, my staff make sure people are reporting. And right now we have about 800 clients we support through the probation program. Yeah. So we partnered with Amanda and her team, and so we had 10 staff who were trained to be peer researchers to assist the bail study. And again, none of my staff have any experience on doing interviews. So we did a lot of mock and did a lot of training. And they also did all the online courses, as you can see there. And they learned how to do REDCap database. And most of my staff have never turned a computer on until they actually started working with us. So hats off to Amanda's team and that for the patience they had as they teach us how to do this. And all the staff consented to the projects and the survey. And let's pass it on to you.
So I'm just going to give us, some information about who were in our participant pool. So we recruited a total of 120 participants over a 6-month period. And like I said, it was a rolling recruitment. So as people came out and they were contacted by UTG, we got their consent and then they got enrolled if they were interested in participating. So most of our participants were male. As you can see from the data, 78% were identified as male with an average age of 37 years. The average number of years they've been in custody over their lifetime. So not just the last time they were incarcerated, maybe people have been incarcerated multiple times. So the average over the course of their lifetime is 8 years, which is a pretty high number, I think. 78% were on parole or probation at the time they were enrolled into this study. And 72% of them went through withdrawal while in custody. In terms of the overdose events reported by participants, so at baseline, that means the day they were released, 70% of participants reported having experienced at least one overdose event in their lifetime. And alarmingly, 14% reported having experienced over 11 overdose events in their lifetime. So we repeated some of these questions when we contacted them again for follow-ups. And at first follow-up, that is 30 days after their release, we found that 9% reported having experienced an overdose event within the past 30 days after they were released from incarceration. And 22% identified themselves, self-identified as being at risk of overdose. I'll pass it on over to Kate now to talk about some of our other findings.
Thanks, Jenyo. Yeah, so one of the main outputs from this project was developing a framework document to guide policy around people leaving incarceration who are at risk for overdose. So Jenyo mentioned all our data capture points. So we captured a ton of data through this project, both qualitative interviews as well as survey data. And we really wanted to make sure we organized it and captured it in a way that was legible and made sense. So we came up with a structure where we first wanted to start looking at participants' experiences and perspectives on some interventions to reduce the risk of overdose. And then we kind of took a level up and wanted to look at some of the factors that might go into influencing their decision-making about those interventions. And then finally, we wanted to look at some of the factors that we actually introduced through our project that might improve access to those interventions. So that is peer support, cell phones, and transportation. So Beth and I are gonna run through what is in our framework document. More quickly, there's a lot more detail in the document itself. We have it linked at the end of the presentation, so I would encourage you to go check it out. And just to reiterate, all of the data, everything that's in the framework is based on participant perspectives and is an amalgamation of both the baseline 1-month and 2-month follow-ups. So these are the 8 interventions that we looked at through our project, and I'm just going to touch on some of the findings of each of them. So the first one, prescribed safe supply. So this is prescribed pharmaceutical alternatives to the toxic drug supply. Participants liked that it was regulated and could be used as a way to transition away from other drugs and to help manage withdrawal symptoms. They also reported, however, that they found prescribed safe supply didn't always meet their needs, in that some of them found dosages weren't sufficient to manage cravings sometimes, and some of them also, either their chosen substances or their chosen method of consumption, so like inhalation, weren't covered under the prescribed safe supply protocol. So opioid agonist treatment, OAT treatment. Again, participants found that OAT was a reliable source of opioids and could help manage cravings. And then in particular for Sublocade, they liked not having to go to the pharmacy every day. Again, some were dissatisfied with the high that they got from OAT, or it wasn't the same as the street level supply. And again, some did feel that the dosages weren't necessarily aligning with their cravings. With substance use treatment, so residential treatment centers, again, a bit of a mixed response. So those who found it really effective seemed to rely a lot on their experiences within that environment. So if they made good connections with people and they felt supported by the other people in the treatment center, they said it was effective. And also if they felt like they went to the treatment center of their own choice, they seem to have a better response to it, versus other people who had mandated court orders to go to treatment tend to have a worse response from their perspective. And again, the abstinence-based approach of most treatment centers didn't necessarily align with some of the participants who would have preferred a broader range of harm reduction practices. And then a huge issue is that people who were interested in accessing treatment centers faced long wait times and big wait lists. So that was a huge barrier to access as well. Naloxone overall, people said they liked having it. A lot had experience using it. Although some did say they had a hard time getting it, and that they didn't know where in their community to go look for it, or their community had a lack of supply. And then there were a few people that talked about the stigma of carrying a naloxone kit as showing them as a drug user, and that stigma was could be a bit of a barrier as well. Overdose prevention sites. So people noted this was a preferable alternative to using alone. Again, OPS didn't always meet the needs of people. So if you were using inhalants, obviously a safe injection site isn't necessarily a space that you would access. And then also people talked about how far away the OPS was from them would impact their likeliness of going to use it. Drug checking services, overall participants reported, didn't report a lot that they were using them once they returned to the community. Same thing with toxic drug alerts. So these are text messages that go right to your phone. There wasn't a lot of reporting about receiving them or using those. And the same thing with cell phone apps. So we are talking about Lifeguard and Brave. And so these are apps designed for people who are using alone, and they'll automatically connect to an emergency contact or 911 if you as the user become unresponsive. So we actually pre-downloaded those apps onto all the participants' phones, but they still, as you can see, had a pretty low reporting of using those apps. So now going on to this kind of second level, additional factors that'll go into influencing people's decisions to use interventions. The first one we'll touch on is overdose risk perception. So this is someone's perception of their own risk. So we found that some people did have a high perception of risk, like they were either planning on using or were actively using, and knew the risks, and therefore were interested in accessing harm reduction interventions. Then we had people who fell into the low perception of overdose risk category. So some of those people were also actively using, but didn't see themselves at risk because they were engaging in other, maybe more informal harm reduction practices. So, you know, they were using from a trusted supplier or knew their limits or that kind of thing. So they were less likely to engage with any of those 8 interventions because they felt like they were protected enough with their own strategies. And then the other category of people who had a low perception of overdose risk were people who were not planning on using at all. So, they were abstinence oriented, felt confident in their sobriety journey, and didn't see any of those interventions as aligning with their abstinence goals. So this is important to be aware of because people who view their risk as low still may be at risk. And we know that risk perception is an important motivating factor for health behavior change. So, an inaccurate perception of overdose risk can actually increase someone's exposure to risk. And then the final one that I'll touch on is just the impact of the criminal legal system for people in accessing these interventions. So this is, coming in and out of prison and how that can create some barriers to accessing those interventions. Court-ordered release conditions. So when you're on probation and you have certain conditions related to substance use, if you have restrictions on movement or curfews, that can impact your ability to access services. If you have abstinence-related court orders, then you're not going to be engaging with these interventions. And just in general, people might be less likely to engage with interventions if they feel like it's going to breach their conditions. And people can experience a disruption in their continuity of care as they're going in and out. So, prescribed safe supply, if you're on that in the community, that's not available inside. And then with OAT, a lot of people actually went on OAT when they went inside, but then that number dropped a little bit when people were being released into the community, which kind of suggests there's some issue with maintaining prescriptions as you're moving in and out. And then kind of paired with that is this idea of a rapid environment change. So, choices inside are limited. So, you don't have access to street supply. So you might be more inclined to try OAT or be interested in abstinence because that's what's available to you. But then when you return to a community, all of your other options are available, meaning you might now have a low tolerance. And again, you're at a higher risk for overdose. And then the last thing I'll just touch on is something that emerged out of the project was we found there was a lot of misinformation about the province's decriminalization policy. So decriminalizing personal possession, which changed kind of towards the end of the project anyways. But when we were talking to people, we found that 82% of participants knew about the policy, but only 27% knew that that policy wouldn't apply to you if you had court-ordered conditions related to substance use. So this misinformation could actually put you at higher risk for breaching your conditions and going back to prison. So because of that, we actually designed a little pamphlet that had some information about decrim, as well as some other resources related to overdose, and then contact information for unlocking the gates as well. I have the link here, but I don't want that to wreck anything. So we have a QR code at the end of the presentation where you can look at both the framework document and then also the pamphlet. So I would encourage you to do that. I'm going to hand it over to Beth to talk about the rest of the framework.
Okay. So another of the factors that influence intervention engagement were social determinants of health, mental health, and related factors. So people being released from incarceration have basic needs that have to be met to help support integration, lower stress, and ultimately reduce the risk of overdose. So things like housing, mental health support, employment and income, and social connections are all really important. If you don't have secure, safe, comfortable, and affordable housing, it's hard to be motivated to set goals related to substance use. We also heard from people that housing can be interrelated with relapse. So for example, if you're staying in a substance use treatment facility that requires abstinence, if you relapse, you also lose your housing. So there's some interrelatedness among all these factors as well. Mental health support is really important. People who have been incarcerated often experience mental health concerns caused by a number of factors, including previous overdoses, poverty, childhood trauma, interactions with police, and incarceration itself. Substance use is sometimes a coping mechanism used to manage these issues, and that puts people at further risk of overdose. We heard from people in our study that there was a strong desire for counseling, both during incarceration and after release, and that there was just not much of that at all, really long wait lists or completely impossible to access. And we also heard about a number of other strategies that people use to support their well-being, including social support, physical activity, artistic pursuits, and spirituality. In terms of income and employment, this is a major priority for people when they're released from incarceration. And in addition to being a source of income, employment was also described as providing motivation for reintegration and offering meaning in people's lives. We heard about a lot of challenges with obtaining employment and income assistance, including things like disclosing history of incarceration for records checks, and also release conditions, which Kate mentioned earlier. If you have release conditions that are, for example, a curfew, it limits when you can work. If you have house arrest and you're not allowed to leave a certain area, but you need to get to an appointment for income assistance. So sometimes release conditions actually are a barrier to meeting your basic needs. And social networks and social connection is extremely important priority. They can be friends, family, and other social supports are a major source of support, and they help people navigate reintegration and work towards their substance use goals. Another big factor was stigma, and this was both stigma related to having a history of involvement in the criminal legal system and also stigma related to substance use. So a lot of people experience judgment from others, social exclusion, having a history of criminal justice involvement can limit, the ability to get housing or to get into certain drug treatment programs, can be barriers to accessing healthcare. Also, having a history of involvement in the criminal justice system can lead to people making assumptions about your guilt for other things. So a lot of people describe police approaching them with the assumption of guilt and really being judged by probation officers and law enforcement in some cases. And then similarly, stigma related to substance use can also be a barrier to housing, can make it difficult to get prescriptions for prescription refills. We also heard about judgment from loved ones, either around substance use or around being in a substance use treatment program, and also internalized shame, so self-stigmatization as well. Stigma can be really isolating and may prevent people from accessing support, which again further increases risk for overdose. The final layer of our framework was around the elements that the Prevail project provided as ways to facilitate access to interventions. So peer support, cell phones, and transportation. So as Jenyo mentioned, every participant was given a cell phone with 3 months of phone and data on it. This was really helpful in many ways for participants. They told us that the number one reason that they used their phone was to connect to that social support, to family and friends and other supports. It also helped connect to other interventions and services. So things like navigating a wait list for a treatment center or setting up an appointment for OAT, looking for other types of housing or employment. You need to have a phone. You need some way people can reach you, and you need to be able to reach people. And this, it's really kind of a basic need in today's society to do anything. So this was a really successful intervention. Transportation, likewise, is really important. Just the ability to move about the community is really vital to support reintegration. The ride provided by Unlocking the Gates Society at the time of the release, it helped ensure, as Mo mentioned, it ensured people got where they needed to go safely. We heard from participants, it really helped them in some cases to avoid going to high-risk environments and getting to their destination. In the time, the follow-up interviews, post-release, we heard a lot of transportation challenges navigating the community, and that proximity and just the ability to get to different locations really affects whether you can engage in some of these interventions or not. And the third element was peer support. So this was one of the things our participants really valued. Having someone show up at the gates and be waiting for you at the gates was a huge way that relieved anxiety. It's a really stressful time. And just knowing that there's someone waiting for you, someone who's been there and really understands what you are experiencing, just really helped relieve a lot of anxiety for people. Knowing someone was going to be there for you and help you navigate and figure out what to do in this stressful time. It also helped to disrupt stigma. People talked about how much hope it gave them to see someone who'd been through similar experiences living successfully in community. It helped them see a hopeful future for themselves. It was also around building community and again, improving access to interventions, having a support that they know they could call at any time to help them with whatever they needed was critical for participants. And I'm going to turn it over to Mo. I think it's just slide, yeah.
Okay. Yeah, so about peer support, there's one other thing too is, we only have 10 correctional centers, and why our numbers were so high for men is that there's 9 for men, 1 for women. So that makes why our numbers were so high for men, especially transportation. Correction, by law, by corrections, that they pay you a bus ticket back to where you were arrested, not to where you want to go. Right. So if you decide that you want to change and go to treatment somewhere else in a different community, no one pays for you to get there. You're left to trying to figure out how to get there yourself. And that's where unlocking the gates comes in. So we have people coming from the Okanagan who need to go to the island, right? But again, there's so few treatment centers would take people directly from jail. Most people want them on the street for 30 days, which is a huge barrier. So we're actually taking people from their community of Kelowna and dropping them off in Victoria where they have no support, nobody. And if they actually, as they said, Beth said, if you actually relapse or, whatever, get in a fight, you get kicked out. Now you're stuck in another community. And that's where unlocking the gates comes in, because we support people no matter if you're just getting out of jail or if you're in the community or at the risk of going to jail. So in stigma, this is the reason why we started unlocking the gates, was because the stigma we all went through coming out of prison, going to buy food, clothing, going to get income assistance, trying to get a doctor's appointment, you just got treated like garbage, right? So having my team there, gives people the confidence, and, people think twice of, talking down to somebody who just got out of prison. So yeah, and building that community, it's hard, everything you were familiar with, the streets, your friends, your community, and all of a sudden, hey, I want to change my life, but now you're going into a foreign community. I mean, a lot of people have never I used to imagine what it was like going to work. I would watch people go in and get coffee in the morning and get gas at 6:30 in the morning. I'm like, I wonder what it's like to even have a job, right? It's something what's foreign to most of us who are incarcerated. But I'll tell you, everyone if I had a dime for every time somebody came to jail and said, that's it, I don't want to use anymore, I'm done. People don't want to do. It's such a hard life being an addict. It's 24/7. I mean, look at it today, it was -2 out in the valley. It's cold to be homeless, right? We just don't have resources out here for people. Even as much as my team, we supported 2,500 people last year getting out of the correctional center, and most of them want food, clothing, and shelter. And I guess the other big one is the biggest thing we give people is dignity the day they get out, right? Because when you get released, you're released with clothes that aren't yours, secondhand clothes, or your dirty clothes, because that's all they give you back. They don't wash your clothes when you get arrested, and they'll sit in a bag. So giving people dignity and having clothes for them, shoes, jackets. So yeah, I'll pass it on.
Thanks. Yeah. So just to sort of wrap up the talk about the framework, as Kate mentioned, the framework is to help people who are planning and implementing interventions to think about some important factors. So some considerations that we included in our framework include thinking about effective intervention communications. So we know we heard about having incorrect information about something like decrim. We also heard about some interventions that are available that aren't being taken up by people leaving incarceration, such as toxic drug alerts and the apps. So it's probably worth looking into why those things weren't taken up. How are they not meeting people's needs and how might they be improved? Another thing was the importance of ensuring continuity of care. Incarceration is a disruptive event, and it really impacts continuity, both when you're going into a correctional facility and when you're coming out. So thinking about ways to improve that continuity is really important. And also providing a sense of personal choice. So incarceration and subsequent court-ordered abstinence or treatment really limits personal choice. And so it's important to think about how interventions can foster a sense of choice and collaboration to meet people where they are, meet their needs, and as Mo really well put, with dignity. That's our framework, and I think I'm passing it back to Amanda to wrap us up. And
yeah, so we do have some resources to point you to at this time. So we have developed the framework, which is very focused, as our team has said, on reducing overdose among people who are leaving prison settings or correctional centers. And that is available on the CCPHE, Canadian Collaboration for Prison Health and Education website. And we'll also be pushing some of this out through social media and the Advancing Health website. And we've also developed a zine that's pretty cool. And it includes a poster with the Save Me protocol on it as well. If you could just go back, Beth. Yeah. And the pamphlet is really cool because it's something that can be provided to people who are leaving custody. And I know Unlocking the Gates has been giving these out, and there's been a very warm reception to them. And really the language here is around welcome back, your life, you matter to us in our community. You are important members of our community. And this is how you can keep yourself safer when you're using substances. And our team is working on a number of different publications and different things to get this information out there. And in terms of next steps, we are also trying to get some funding to be able to continue this work, because we did enrollment extremely quickly with this. There was extreme demand for this intervention. I know Unlocking the Gates is still getting calls to this day for this program, and we do think it had a beneficial impact. We didn't report on it today, but we did collect data on non-fatal overdose after receiving the intervention with the cell phones, the peer support. It was lower than our previous studies where people didn't receive the intervention. So next slide. Just to wrap all this up, to say the work of Unlocking the Gates is extraordinary. They're there every day, meeting people where they're at and giving people hope and dignity. And more than ever, given the highly stigmatized media coverage and just language as often used to describe people who are engaged in the criminal legal system, really organizations like Unlocking the Gates and peer support are really needed more than ever to meet people where they're at and to bring people out of the shadows. And this connection to healthcare and social services and basic needs such as food, shelter, and clothing is really needed more than ever during the cost of living crisis. And so I just want to say thank you so much to our team, especially kudos to our friends and colleagues at Advancing Health and Unlocking the Gates. Thank you so much.